Hey, Jarna, how are you?
I'm doing well. How are you doing, Raj? Good to
I'm
see
doing
you.
wonderful, wonderful. And thank you for being patient. I know we're running a little bit behind schedule, but again, hard to stop talking about these topics when everybody's so passionate about them. And I feel like I'm holding back myself, trying to make sure I don't ask too many more questions. But they're very interesting. So, next up, you are going to be talking about chronic pain management in pregnancy, correct?
Yes.
All right, let's get your slides up here.
Perfect.
Perfect. Go for it.
Okay. Well, hey, everybody. My name is Jarna Shah. I am a recent transplant to St. Louis, Missouri. And we've talked a lot about urology, regional anesthesia, and cardiology and procedures. So we're going to pivot a little bit and talk about how we manage pain during pregnancy. This has been a passion project of mine for many years. Here are my disclosures, none that relate to my talk. And my goals here will be to talk a little bit about the prevalence of chronic pain in the parturient and look at the most common pain states that we may see and look at the evidence and talk about what treatment options we have for these patients. There is this myth that pregnancy in women with chronic pain is rare. And I hope by the end of the talk, I'm able to convince you that it's something we should be paying more attention to. If we look over here at just our general numbers, we have a quarter of the population of young adults who report having chronic pain. We know that there is a predominance for women over men to have more chronic pain conditions when we think of fibromyalgia and widespread diffuse types of pain. In general, the stats show that there are about 5.3 million pregnancies a year, with 3.6 million of these going to live term births. So let's look at that Venn diagram, basically. If you have around 60 million women in this young adult range, even not even going all the way up to 65, but 18 to 45 with chronic pain and about 4 million pregnancies, we are going to see more of an overlap with this. As we numbers for chronic pain also increase in our population, and our maternal age also increase. We are going to see more of these people in our clinics, in the perioperative setting, even as they plan to talk about when they're ready to conceive and what our options are. You can see that the steady trend over the last several decades is a growing number of pregnancies over the age of 30, and by our current measurements, we still call pregnancies over the age of 35 advanced maternal age. So as we see that, and we also have to think about how many pregnancies are unplanned. How many people do we see every day around procedures, around clinic visits, who are just women? And if the number of unplanned pregnancies is nearly at 50%, are we truly counseling our patients about what their options are? Now, interestingly, because of the hormonal shifts during pregnancy, there are some conditions that do improve during pregnancy. There are some that also worsen a lot. Autoimmune conditions can improve with your hormonal shifts with relaxing. Looking at your headaches, typically you do see an improvement and a decrease in the number of headaches and MS symptoms. There are a lot of conditions that worsen as well. Carpal tunnel would be an example. The American Society of Hand Surgeons says that nearly 62% of women during pregnancy will experience carpal tunnel-like syndromes, especially in that third trimester, where you have nerve impingement or any type of tenosynovitis. Lower back pain being very common, as well as pelvic girdle pain. And something I want us to also think about is what types of medications do our patients take? What type are taking? There are some old classifications over here that were used before, I believe, 2011, looking and categorizing which medications are safe for pregnancy and which are not, based on the A through D rating. If you think about the medicines that people come in on, there are lots of people on these SNRIs, on these muscle relaxers, on NSAIDs, on all of these medications, and you can see they don't rank favorably on this pregnancy category uh, system from the FDA. The newer system over here has kind of changed the way we look at categorization, to look at overall risk summary, and to look at pros and cons and make the process overall more shared decision-making model for patients and providers. Let's talk a little bit about some of the conditions that worsen in pregnancy and why. So with the increase in lumbar lordosis and your ligament laxity, you have a gravid uterus that is putting more pressure on that lumbar spine, and that increased weight gain too is also adding to that. If somebody has some pre-existing sciatic pain or a lumbar radiculopathy from an impinged nerve or a disc herniation, you can absolutely see exacerbation of those symptoms during pregnancy. And it can be debilitating to the point where people are no longer able to move around without hurting, even anywhere past the second trimester. The incidence can be quite high. Papers will cite that its incidence is just very in nature. The risk factors include BMI, a history of lower back pain in a previous pregnancy, if the parturient has a history of any joint hypermobility, advanced maternal age. And you can see over here a lot is postural changes, but in addition to that, you just have the increase of relaxin, and everything just really kind of worsens just as you're carrying that gravid uterus to exacerbate that type of pain. Pelvic girdle pain is another good example. If you think about the biomechanics of how the body moves and functions, you have an exaggerated pelvic tilt, which means more pressure on that sacroiliac joint and also pressure on that pubic symphysis too, which can also be a source of a lot of severe pain. Uh, we do have a lot of persistent postpartum pain too. We have pelvic pain that continues even 2 years postpartum, and this can be something that affects patients during that 4th trimester, as well as with their recovery in their future. We think about, are they able to participate in society? Are they able to continue working? Or is this pain something that really follows them and prevents them from having a better quality of life and being part of the workforce? I like to think about the 4 treatment arms kind of like the spindles of a chair, and I think that if we look at medication management as well as procedural treatment options, in addition to physical therapy and pain psychology, we can have a more effective treatment strategy for these patients. When somebody is pregnant, there are treatment options we can provide for severe types of pain that are refractory to conservative therapy, medical management, and PT. We can do ultrasound guided blocks, and this is where I think regional anesthesia can really shine. Typically, it's recommended that this is done in the second trimester because of the use of steroids. Second or third trimester is preferable for this compared to the first trimester. Of course, data is very limited in this. But if you can visualize this under ultrasound, it is better to, according to what we know, it is better to treat the area locally and regionally compared to systemic treatment. In terms of bupivacaine, there is minimal maternal to fetal transfer of that medication, and it is safe according to what we currently have guideline-wise. Looking at the risks and benefits, there are no adverse risks for using corticosteroids like dexamethasone in the second and third trimester. It does not affect fetal lung maturity from what we know. No adverse effects have been reported for using this for a local type of injection. Another type of thing too is an ultrasound guided sacroiliac joint block. We typically do a lot of these under fluoroscopy. Of course, that's contraindicated during pregnancy, but in second or third trimester, if an SI joint band is not helping, there is to do an ultrasound guided block over here. Around the time of labor and delivery, in the perioperative period, the neuraxial type of epidural anesthesia still remains the gold standard for cesarean delivery and just for managing pain. If you have a patient who is a chronic pain patient coming up, it makes sense as much as you can to place that epidural to provide them with a non-opioid based analgesic for the process and the recovery as well. Right now, these guidelines were released in November of 2025, and these are the most up-to-date guidelines we have for management of these patients for OUD around the time of pregnancy. And I've linked that over there with that QR code. And I want to focus for the last few minutes on what you do when a patient comes in with a device. We're seeing this more and more, whether it's PNS, SCS, DRG, all of these things. How does this affect the pregnant patient? What do you do if somebody comes in? And also, what do you do if somebody comes in for surgery and they have one of these implanted devices? This is kind of applicable to both of those situations. So for the pregnant patient with an implanted device, here's a case series that's out of Rush University looking at a sample of 7 patients who they tracked at the time of pregnancy and how their patient's delivery process. A lot of these were cesarean deliveries for other reasons. You can see a lot of repeats. But for the CRPS pathology, you can see the age for implant is quite young. It's a devastating disease, and these are people who are of childbearing age. This is the important part over here that I want to focus on. If you have a patient who has an implanted device, it's important to understand the entry point of those leads. For cervical types of pain for upper extremity, the leads are cervical and nowhere near where you would need to do any sort of regional block. The simulator itself, for the most part, best advice we have currently is to keep it off for the duration of the pregnancy and delivery. There is one number 3 who did have their stimulator turned on during gestation. From this very small case series, you can see that the neonate status was healthy without any complications related to the stimulation. And can your patient receive regional anesthesia? Things I would recommend would be to review imaging of your device, your battery, and your leads. Now, if I'm placing a spinal cord stimulator to treat lower extremity or low back pain, I will typically enter in the upper lumbar region. The leads can extend anywhere from T6 to T10 or T11, and the spacing of that is dependent on the location of the pain. If it's in the cervical region, sometimes you can still have an entry in the lumbar spine with the leads thread. Typically, we enter in the upper thoracic spine. If somebody is pregnant or laboring, it's very appropriate to do either single shot spinal without affecting the device. It's also reasonable to place an epidural, a CSE. I recommend going in the lower lumbar spine, L4, L5, and minimizing overthreading of your catheter. The simulator is placed on surgery mode. It does not interfere with the dosing of the medication you want to use. This also applies if somebody needs an epidural, like let's say a thoracic epidural. These were the things I would keep it if they're having any type of thoracic surgery during pregnancy. It's important to think about these patients as really understanding their quality of life as well. The CDC does recommend that we should be cautious with opioids in pain in pregnancy, but it's not a reason to avoid treating. I'll briefly address the fact that there have been some recent publications stating that acetaminophen is safe during pregnancy. These studies are a little slanted. They are not indicative of the overall body of evidence we have. Acetaminophen is still very much our first line of treatment for patients during pregnancy, and it should not affect the fetus. The key takeaway points I want to mention and just kind of bring back to here is that prevalence of the chronic pain state in parturients is really defined. Any chronic pain condition that can occur in young women is superimposed on pregnancy, which makes this a really challenging population. One point that I want us all to think about is how much are we actually talking to our patients about how they need to change their medications if they're looking to conceive or may not even be looking to, but just may not know. Unanticipated pregnancy is common. Are we discussing medication side effect profiles with patients around the time of surgeries, around the time of their clinic visits, with any patient of childbearing potential? Thank you really much. Thank you very much for your time. Thank you, Raj and Rakesh, for putting this all together, and I'll turn it back to you.
Thank you, Jarna. Wonderful presentation. Pregnancy is, we sort of think a regional is just stick the epidural in, but there's so much more there.
Yeah, especially when pregnant women come with chronic SI joint pains and you cannot do fluoroscopy and they still need to provide pain relief. So thank you for this amazing presentation. Gives us a new perspective of we can apply regional anesthesia and neuromodulation in this special population.
Thank you very much.
Yeah, and Jarna, we're looking forward to see you at the meetings, and we'll keep on the conversations when we get there. Good to have you here, Jarna.
Thanks for having me.
Take
Have
care.
a good rest of the session. I'll be watching.
All right.
Thank you.